Assalamu alaikum. Good morning, everyone. I first of all would like to thank everyone, the organizing committee, for the invitation and for the great hospitality. It's wonderful to be here in Riyadh, and I feel nostalgic. I have some fond memories of Riyadh. Have been worked in initial days of my career as a resident at King Fahd Medical City, where I used to be young and with nice hairs. So, I would go over the overview of today's presentation. First of all, brief introduction about adverse risk KML, then update on risk stratification, how the risk stratification evolved over time till now. Then we'll talk about venetoclax-based therapy for adverse risk AML, and then briefly highlight the immune signature and the significance of immune signature in AML diagnosis and management. We'll go over AML with MRC, then focus some studies which have done for evaluation of p53-mediated AML, and then lastly but not the least, the menin inhibitors, which have been the new novel agent which has been implied for the management of AML and some adverse risk AML. So adverse risk AML, it's a disease which inherent resistance to conventional chemotherapy, and these patients, although some of them achieve remission, but these remissions are short-lasting, and when these patients relapse, they tend to have a poorer outcome. Commonly, this disease is seen in elderly patient population, patients who had prior chemotherapy, and these patients are most commonly not eligible for intensive chemotherapy approaches, including bone marrow transplant. So, few slides how the risk stratification and the classification of AML evolve over time, going through the back days where it used to be like more morphologically oriented classification of AML and less emphasis on molecular and genetic features. With the passage of time, we have learned how the heterogeneity of the AML can be dissected and how we divide these patients who have a favorable outcome versus those who have an unfavorable outcome, with making more attention towards the molecular classification. And as you can see, the adverse risk population or adverse risk group of AML has evolved and expanded over time until recently, where we can see that ELN22 classification, the risk category, the adverse risk evolved with more splicing mutations and more mutations by who can define as anticipated AML. And as well as one important thing to note in this recent classification, the FLT3-ITD mutated AML, which tends to be a poor prognostic AML, now more and more considered a poor prognostic AML and fall into intermediate category with the advent of novel TKI, potent TKI-based therapies which have improved outcome of this group of patients. One thing to note, that this classification system is based on intensively treated patient population. It may not imply the current phenomena where we use more and more venetoclax in our treatment regimen, not only with combination with Vidasa, but also with intensive chemotherapy in younger eligible patients. So venetoclax-based therapy, this has been the paradigm shift in the management of AML, not only elderly AML, but also in younger AML who have adverse risk phenotype. This is a study by Courtney Renardo from MD Anderson, who tried to explain the molecular profile and molecular signature, which can predict how these patients will respond to venetoclax-based therapy. As you can see here, patients who have SRS2 mutation, IDH1, IDH2 tends to have a better response to venetoclax-based therapy with better MRD clearance. On the other hand, the adverse risk group, including those with monosomal complex karyotype, 17p deletion, or p53, they may respond to venetoclax-based therapy. These responses were short-lasting because the persistence of highly potent p53 clone and other high-risk adverse phenotype. At last year ASH, Hartman donor have developed this immune signature that can help in appreciating how the AML patient respond to venetoclax-based therapy, dividing to three main groups. Those with p53 tends to have adverse outcome, and those who doesn't have p53, FLT3-ITD or RAS mutation tends to have a better response to venetoclax-based therapy. So we know that the splicing mutation, spliceosome mutation, including UTF1, SRF2, has fallen into the adverse risk category, and these patients tend to have adverse phenotype, and those who are eligible for intensive chemotherapy should be proceeded to bone marrow transplant to improve their long-term outcome. The group from MD Anderson did a retrospective analysis and tried to find the significance of venetoclax-based therapy either in combination with low-intensity chemotherapy or intensive chemotherapy, they found that these can abrogate, they nullify the poor prognostic impact of splasmodium mutation, including SRF2, U2F1, and ZRSS2. At Mayo Clinic, we did our Mayo series of patients who have U2F mutation that's shown to be one of the adverse risk plasmodium mutation in myeloid neoplasm, and they found that there's a heterogeneity among this group of patients. Among the two most common amino acid sequence of U2F variant, which we see, one is Q157P and other is S34F. These have heterogeneity, and the more Q157P is clustered with P53, AXL1 and high risk mutation, and those with SRF34F are clustered with more low risk mutation, and these mutation tends to dictates the survival. Those with S34F tends to have a better outcome compared to those with 157P. And the bone marrow transplant tends to improve the outcome overall, irrespective of the amino acid sequence. So one thing more to learn apart from the adverse risk mutations, some variants and variant frequency does predict outcome among these adverse risk AML patients. So it's always challenging when you have a patient who has borderline 65 to 70 years of age, who may qualify for intensive chemotherapy, but may have some overlapping features or adverse risk phenotype. What agent do we choose? Either we go for venetoclax-based therapy that may tend to do work better in adverse risk AML, or do intensive chemotherapy and take these patients to bone marrow transplant. The researchers from UPenn did their EMR-based study in which they divide these patients who receive intensive chemotherapy versus those who receive venetoclax-based therapy and did some analysis. However, the venetoclax-based group had a more high-risk patients, elderly, who may have prior therapy-related AML, but the intensive chemotherapy-treated patients have a better outcome. However, doing multiple imputations and mitigating the adverse risk phenotype, the outcome remained comparable between intensive chemotherapy as well as venetoclax-based regimen. So prospectively trial are warranted to delineate these two modalities of treatment and to identify which patients tend to do better with intensive chemotherapy versus those who can do better with venetoclax-based therapy. So as we all know, with the passage of time, especially for elderly adverse risk AML, venetoclax-based therapy has evolved, and more clinicians are inclined towards treating those agents. So we did our real-world data from AML consortium across 10 academic centers, and though we found out that venetoclax has been more and more implied in the treatment of AML with P53 mutation, as you can see on the right side of the curve, the big green bars. However, the outcome remains dismal, with median survival in the range of 6 to 9 months. That suggests for this subgroup of patients, as Dr. Hazarjin mentioned, these are poorer risk group, and there's a separate entity to be recognized. These patients continue to do poorly with available novel agent therapies, including venetoclax. So we know that AML, development of AML, does happen with some immune suppression and immune exhaustion that leads to the AML diagnosis. And we also know that BCL2 inhibitors like venetoclax in combination with hypomethylation agent tends to overcome that immune suppression of the AML and activate the cytotoxic T cells. And we also know these high-risk group of patients with P53 tends to have a more immune-rich, immune-infiltrated phenotype. So we did an IIT and tried to understand the immune profile of AML patients who receive venetoclax plus HMA-based therapy. And we able to identify 35 clusters among this group of patients using CyTOF, single-cell mass cytometry, analysis which expands the immune profile, immunophenotype of the AML patients. And interestingly, we found that the P53 mutated patients cluster with immune-rich phenotype. Among the 35 clusters we identified, we found that the B-cell activated phenotype, effector memory CD8 T-cell phenotype are more rich in these group of patients, suggesting that immune-rich phenotype of this P53 AML and immune-based chemotherapy approaches may have a role to improve outcome of this group of patients. On conversely, the patients who have an immune-depleted phenotype and immune-exhausted phenotype, they tend to have a better response to VEN-HMA-based therapy, supporting the evidence that venetoclax-based combination can upregulate the cytotoxic T cells to have a better cytotoxic treatment in response to these therapy in patients with AML. Though the venetoclax has been a paradigm shift and improved outcome of certain group of patients, but there are still significant proportion of patients that tends to do in suboptimal or poorly with this combination approaches. There are various mechanisms that are studied and been known why these venetoclax-based therapy doesn't work well in all the AML patients. Among that, most importantly, as you know that the venetoclax require intact B cell 2 apoptosis mechanism to induce cytotoxicity, which is impaired in p53-mutated AML. Similarly, sometimes the alternating apoptotic pathway get activated, like MCL1, BCL-XL, and BCL-W, which can inhibit the effectivity of the venetoclax approaches. And this group also includes the patient with FLT3 ITD-mutated AML. So we need to work along those lines, have a better triplet combination of better individualized therapy, how to overcome this resistant mechanism, improve outcome of our patient with adverse risk AML. We'll talk briefly about AML with MDS-related changes. This is more commonly seen in elderly AML population, and those patients have significantly overlapped with high-risk cytogenetics. According to recent ICC classification, apart from the chromosomal changes that define AML with MDS-related changes, there are certain molecular markers that can define AML with MRC, including XL1, splicing mutation, and some others. And substantial proportion of these patients had prior progression to HMA. Historically, patients who progressed on HMA-based therapy and transformed to AML, their outcome is less than 6 months. With venetoclax-based therapy, they may improve to 6 to 9 months, but still very poor. As you know, the CPX351, it's a liposomal combination with a cyclin cytarabine, which give more leukemic activity of the 3+7 combination in patients with AML. It is approved for patients who had a prior MDS or had AML with MRC changes, or those who have therapeutic AML, and has shown to improve outcome in this group of patients, especially those who can bridge to bone marrow transplant. Recently, a randomized study conducted by UK group evaluating the benefit and efficacy of FLAG-IDA, another intensive chemotherapy regimen, compared to CPX351. They found, interestingly, those with MDS rate changes tends to have a better outcome with CPX, which may be better tolerated than FLAG-IDA chemotherapy. However, patients with p53-mutated AML tends to have a worse outcome with no benefit of either of the two combination. So moving towards the p53-mutated AML, which is my area of interest. As you know, the p53 is not only involved in cell regulation, genomic stability, apoptosis, but also has a role in innate and adaptive immunity. It's a mutation which commonly occur across all cancers and have the inferior outcome. And it's an AML, although it's seen in a small subset of patients, but those who are elderly, who had a prior chemotherapy or therapeutic AML, tends to have a higher likelihood of this poor prognostic disease. And these AML patient doesn't respond well to conventional chemotherapy approaches. Over the years, several chemotherapy combinations have been tried with moderate responses, as you can see in the red, with the response in the range of 40%, apart from one small prospective study from WashU, where they find the 10 days decitabine tends to improve the outcome of this patient with clearance of p53 clone. However, it doesn't pan out in combination with venetoclax-based therapy in further prospective studies. One agent that shows to be promising is maculimab combination, which is anti-CD47, which is an immunotherapy-based approach in combination with HMA or HMA plus venetoclax that's shown to improve outcome. And there are 2 randomized studies are ongoing to see the efficacy of this combination versus standard of care therapy. With more to be learned about this combination, but so far the data seems to be exciting. The role of transplant. Historically, it is thought that this high group of AML patients may not respond well to bone marrow transplant, and it's not worth taking the risk with high morbidity and mortality, which can be seen in bone marrow transplant. And the lack of benefit has been shown to persistent of p53 clone. In our real-world analysis, most recently in the venetoclax-based era, we did found that the only factor which improves the outcome of these high group of patients with bone marrow transplant. We did this analysis to find the predictors. What are the predictors that suggest that p53-mutated AML may tend to have a better outcome with bone marrow transplant? Although, as you can see on the right-hand side, very small proportion of patients were able to undergo transplant, around 10 to 13% after first-line or second-line therapy. However, among those patients who are bridged to transplant, they tend to have a better event-free survival, more than a year, and better overall survival after first-line therapy, close to 3 years. Not only that, in multivariate analysis, we found that patients who develop chronic GVHD or who are in CR at day 100 post-bone marrow transplant, that tends to have a best outcome. As you can see here, the 4-year survival around close to 40 to 50%, which is never heard of with whatever therapies we have available to treat this poor prognostic disease. Some of the evidence may suggest that graft leukemia effect may have a role to play in terms of sustaining an improved outcome for this group of patients. Having said that, these are small subset of patients, most likely because when we are treating these patient population, these are elderly, they are ineligible for intensive chemotherapy, have a lot of comorbidities, and have a relatively high treatment mortality. That's why it doesn't pan out in larger group of patients, but it's still in eligible patients, properly selected patients, that is still a modality to improve their long-term outcome. There's also debate about allelic state and outcome for this group of patients. Initial studies by Bernard et al. Showed that patients with MDS, low-risk MDS especially, if they have a monoallelic p53, tends to have a similar outcome to wild-type p53 compared to biallelic p53. However, later on, when this monoallelic versus biallelic was tested in high-risk MDS and AML patient, doesn't show to have any significant impact in terms of allelic state. We did this our real-world analysis in trying to find out if the monoallelic versus biallelic p53 have any role in high-risk MDS and AML patients in predicting long-term outcome. One observation we did found that single hit p53 tends to have a high cluster of somatic mutations compared to biallelic p53, as has been shown earlier. However, we didn't see that it impact event-free survival or overall survival in high-risk MDS and AML patients. Most likely these patients are high-risk group, acquire more mutation with time when they progress from MDS to AML. Most of these patients may have a prior therapy at AML. Most of these patients may have a prior HMA-based therapy that tends to have negate any significance of allelic state in terms of affecting their outcome. So another adverse risk AML that we need to work on that continues to have a very poor outcome is inversion 3 or translocation 3-3. This group of patients, they have twofold oncogenic event. One is the overexpression of MECOM, and the other is the hypnosufficiency of a GATA2 mutation, which is a transcription factor. Recently conducted retrospective analysis of MD Anderson, they find to figure out how these patients do in venetoclax era of venetoclax therapy. As you can see here, the composite CR is around 40%, and it hasn't changed with intensive versus low intensive chemotherapy. With the venetoclax-based therapy, the complete remission rate is around 33%, and the overall survival at 3 years is really dismal, less than 10%. So these group of patients, adverse risk group of patients, we need to find better strategies how to improve their outcome. Lastly, but not the least, few slides of menin inhibitors. As you know, the menin with the lysine methyl 2 transferase 2A, which is the cofactor in leukogenesis of not only for KMT2 DA deranged AML, also NPM1. And we'll talk about basically on KMT2A, which is an adverse risk phenotype in acute leukemia, overall AML or ALL. Although it's seen in a very small subset of patients, but these patients tend to do poor with conventional chemotherapy, and bone marrow transplant can salvage few eligible patients. Among several menin inhibitors, one of them which is most mature and the data has been presented as a phase 1, phase B study is revumenib with Syndex, a potent oral selective menin inhibitor. In a recently published phase 1 clinical trial, it has shown activity in relapsed refractory patient population, not only those with NPM1 mutation, but also those with KMT2 deranged. Mind you, there are several other menin inhibitors in clinical practice which haven't shown much signals, especially in KMT2A deranged AML. Most of those menin inhibitors have shown activity in NPM1 relapsed refractory AML. So this is a newer compound and a lot to be learned about this menin inhibitors, and there are several trials ongoing in combination with intensive chemotherapy as a frontline for NPM1 and KMT2 deranged AML. So in summary, I would say for adverse risk AML, one size does not fit all. You need to have a better, more individualized approach intensive chemotherapy may not be the answer for this group of patients. Low intensive chemotherapy may have a comparable outcome with less cytotoxicity and better quality of life. And as you need to be focused on more individualized therapy, more incorporating more genomic data, and novel treatment combinations and clinical trial participation for this group of patients is always preferred. Appropriate patient selection, bone marrow transplant can be used effectively to improve the long-term outcome of these patients. And recognizing resistant mutation early and using combination to overcome those resistant mutation is the way forward to improve outcome of this group of patients. With this, I thank you all for listening today.